Hi everyone, it's Dr. Anokhi Khanum. We're trying again to go live with Dr. Sabiha. We've been having technical issues. Just give us a second. We're going to see if we can sort them out. Okay, one person's come on. It's Freya. I see Dr. Freya. I do not see Dr. Sabiha. Sabiha is watching. And no, I cannot see you. Yes. Okay, Sabiha, I'm adding you. Perfect, Sabiha.
Okay, now?
Yes, perfect.
Okay.
Thank you so much. Thank you so very much. Hi, everyone.
Thank you.
So I'm Dr. Anokhi from the Apple Tree Pediatrics. As I promised, I have here Dr. Sabiha Hussain from California. Where are you? San Diego, no?
I'm in San Diego and
Yeah.
I'm associate professor at UCSD.
Yes. And you are a general pediatrician as well as you have a training in infectious disease in pediatrics also. Yeah.
That's correct.
Okay. All right. So I think we'll just dive into it right now. So one of the most common issues, Sabiha, is what we have, which I'm sure we have all over the world with all parents, is my child is constantly coming down with a cold. Okay? Constantly coming down with a cough and a cold, constantly coming down with a cough and a cold. So how many times a year can a child, a toddler sort of under 6, get a cough and a cold a year? The viral ones.
Well, you have what's called the extreme, which is, we call them the normal unlucky child, who can get as many as 1 to 2 infections every couple of months. So they can even come down with like 6 colds in a year. And while parents may see that as abnormal, they are really within the spectrum of normal. We just call them the normal unlucky child, because cold itself is not a trigger for something more serious unless you end up with some more serious infections.
Yeah. And
that is something.
Yeah, and I usually tell the parents, you'll notice when your child is in school, it's like practically every month during school time, they're coming down with a runny nose, cough, cold. But in the summer and winter breaks, they're completely fine. So maybe we can touch up upon that.
Sure. What happens is that, especially younger children, when they are first exposed to a lot of children who are new to them, they tend to pick up a lot of infections and colds and viruses, and they start coming down with a lot of them because they have never been exposed to these viruses before. They have no immunity at all. So parents, a lot of times in the American system, when they start sending their children to daycare, they'll start coming back really worried that my child who was healthy is now getting sick pretty much every month or every other month. And the same thing applies to when they start school, because again, now they're suddenly exposed to all these brand new viruses they've never had before. So these children will be fine in the summer when they're not exposed to so many children and when they're mostly at home. In addition, at certain months of the year, there are more viruses circulating. So combining those two factors together, you'll have the normal healthy child coming down with a lot of things, which will really stress out the parents, but it's still well within normal.
Yeah. No, thank you. Thank you for reinforcing that.
Sure.
Just to highlight important things to remember, my parents of Karachi, some things that I've noted that you guys have been very naughty about is that sending your sick kids to school. I keep getting a complaints. Okay, I sent my child to school, they were completely well, and then when I went there, I saw these other kids with runny noses and coughs. And there are also certain instances where the parent says that, oh, my child had fever this morning, but it's okay, I gave some Calpol, and the child is fine now, so I'm sending them to school. What is your opinion of that, Sabiha? When a child has fever and the fever comes down, they're like, okay, they're okay now, so I can send them to school.
Well, it's probably okay for the child, but the child will be exposing other children to the same viruses that they have. So it's not going to be very good for the other children and their parents. So it's better to wait till they're out of that infectious stage and then send them back. And also give the child enough time to recover, because when they get sick, their immune system goes down a bit. If they get more rest in the house for a couple of days, then it would be beneficial for them as well as the kids around them.
Another question, role of cough syrups in children under 6.
Well, over here in the US, we do not recommend cough syrups at all. For children, especially younger children, the over-the-counter cough syrups have actually shown themselves to be more harmful than beneficial. And we absolutely go against using cough syrups in that age group. There are a couple that are purely based on with honey and a little bit of olive oil possibly, which we sometimes recommend in younger children. But those can be just as easily given at home in just the form of honey. So there really is no role for cough syrups in coughs in children, especially in this age group.
And I just need to reinforce that honey is not allowed in children under 1, because over here they give it a lot.
Oh, definitely no child under 1 should be getting honey, because that can be very dangerous.
Could you explain why could it be dangerous?
The reason is that honey can sometimes harbor a type of toxin caused by bacteria, and if a child is exposed to that toxin, it can cause serious problems like paralysis.
Okay.
Children under 1 are more susceptible. Older children are no longer that susceptible to this.
Yeah. And usually after 1, it's something that we recommend all the time when your child has a cough and a cold, is honey. And there's actually research behind it, as you know, and the saline nose spray, keeping the nose clear and flush.
Yes.
I wanted to come and touch upon also on bronchiolitis. Could you explain what bronchiolitis is?
Bronchiolitis is a condition which is usually caused by a virus known as RSV, but there are a few other viruses that can cause it. And basically what happens is the virus triggers what we call an inflammatory response in the small airways of the lungs. And this leads to irritation and mucus production, and basically narrows those small airways that are in any case very small in children who are most susceptible. So they start to have a hard time with their breathing. And it's usually a relatively benign condition. It doesn't lead to, in most cases, in children who are otherwise healthy and were born on time, they do usually recover on their own without any extra special treatment, except sometimes they might need a little oxygen if they're admitted to the hospital.
Is there anything we can do at home to treat the child with bronchiolitis?
There's no specific treatment that should be done in the house. If the child is having problems with his breathing because of the bronchiolitis, he should definitely be seen by a doctor.
Yeah, okay. So over here, I'm going to do something a little controversial. Over here, people, there is a strong recommendation for doing saline nebulization, normal saline nebulization in children with a cough. What is your opinion on that?
While that probably will not harm them, it will not really do any good either, so I would not recommend it.
Yeah. So we usually tend to use it as placebo in experiments.
Absolutely.
When we do in experiments. Yes. And for those of you who don't know what placebo is basically, we know that when we hand you a medication, the mere fact of handing you a medication will make you feel better, that you are doing something. So when we do experiments to see if a certain medication is working or not, we always give one group the medication and the other group just sugar tablets. And they don't tell either who has gotten what. And then we see how the medication has worked. And then we check whether it's actually the medication group that is showing improvement or the placebo. If it's the placebo group, then we know the medication is not working. So that's basically what placebo is. All right. What are your thoughts about ipratropium bromide in bronchiolitis, commonly called Atom in Pakistan?
We do not use it here. It has had some previous benefit in patients with asthma and was used for that, but it's not used here in bronchiolitis
at all. Okay. All right. All right. All right. So, do you guys still use nebulizers at home, or are you for children with wheezes, for example, or are you guys using your inhalers?
It's situation by situation. Inhalers are the first line that are recommended primarily. And here we also have to consider insurance companies. They preferably use cover the inhalers. However, in some situations, especially younger children, we do see that younger children may respond better to nebulizer treatments. So we'll give that a try if the inhaler is not working as well, and take it from there.
Okay. All right. Steroids in bronchiolitis, nebulized steroids. So there's this drug called brand name Clenil composite. It's a combination of a steroid and albuterol, which is a short-acting beta-mimetic. What is your opinion of using those during bronchiolitis?
We don't use those at all here. Steroids have no place in the management of bronchiolitis. And even now, albuterol is not really being recommended anymore, although it had a slight role before. So I would not recommend it.
And it's just important for people to understand bronchiolitis is different from your viral induced wheeze that can happen in older kids. All right.
Correct.
So the next thing, since we've already started mentioning wheeze, I'd like to touch upon that. If you can tell me a little bit about the viral induced wheeze or the episodic wheeze.
So a lot of younger children, we see wheezing at an early age, and it tends to occur intermittently, usually during any viral infection that can trigger a wheeze. A lot of parents are very concerned when we say that there's wheezing, because they say, then does my child have asthma? But what we like to tell them is that we do not want to diagnose asthma in young children, because wheezing is a very common phenomena in younger children with any virus because of the anatomy. If you look at the small airways in children, they're much smaller than adults. So even a small narrowing can be very significant, and this leads to that whistling sound. So it's something that's relatively benign. It's not something to worry about, and it typically resolves on its own without any intervention.
But we do sometimes use albuterol for the wheeze.
That's reasonable, and that we do sometimes, especially if it shows to have some benefit. But the parents should feel relaxed that it doesn't necessarily mean their child is going to be needing to use an inhaler in the long term.
Yeah. Okay. All right. Another question. Is there anything, so a child has come down with a runny nose and a cough. A lot of parents, as you know, in Pakistan, we have an massive use of antibiotics, abuse of antibiotics, right? So, which is completely understandable. But I have a lot of parents coming in who would be like, my child is having a runny nose and a cough. How do I stop my child from developing a secondary chest infection or pneumonia? So is there anything you can do before to stop the child from developing a pneumonia?
Well, occasionally I've had that question here too. And the main thing that I would say you can do is immunize. Make sure your child gets all the shots, because as you know, the Prevnar shot, the pneumococcal shot, helps to prevent many different types of possible causes of pneumonia. So just make sure your child gets immunized with all the age-appropriate vaccines. And then the influenza shot is something that we recommend as well, though that is in a somewhat separate category from regular chest infections and pneumonia.
Yeah. So just to inform the parents, so your Prevnar, your pneumococcal vaccines is part of your EPI vaccine. So if your child has had their regular vaccination, they should be immunized against with Prevnar. So that shouldn't be an issue, because I'm going to have a lot of parents worrying and running about, has my child been immunized? So if you're following the regular EPI vaccine, even with no additional vaccines, your child should be covered with that. Hand washing, rest, fluids.
Hand washing is very important. It's definitely one of the most important ways to prevent transmitting many different types of infections. So we always reinforce that, good hand hygiene.
The flu. So before I say the flu, just to reinforce what Dr. Sabir has just said, there is literally nothing other than rest, hand washing, and most importantly, ensuring your child is completely up to date with the immunization to prevent them from developing a secondary chest infection. Okay, so there's no amount of cough syrups, medications, taking unnecessary antibiotics when this is clearly a viral infection that will stop or prevent a secondary chest infection. Okay. The next, oh, you touched upon the flu. So what is the flu and how does it differentiate from a cold?
So the flu and a cold may have many overlapping symptoms, but the most important difference to differentiate between the two is with a cold, typically you just have a cough, runny nose, and sore throat, and the rest of the body is not really involved. But with the flu, you will have usually high fevers, you'll have muscle aches and pains, headaches, body aches, and you may even get vomiting and diarrhea as well. And typically, children with the flu and adults for that matter will look much more sick than a person who just has a cold. A lot of times when you walk in the room, they will be lying down, they will just be looking unwell, they may be having chills, or they'll give a history of chills and feeling very, very cold and chest pain. You don't usually have that with just a common cold.
Yeah. So I usually, what we used to say in London was, do you feel like you've been run over by a freight train? No, then you don't have the flu. If you feel like you've been run over by a freight train, then yes, very likely you have the flu. Okay.
Yes.
And flu vaccines, those are the influenza vaccines. If you could just talk a little bit about those, like what are the flu vaccines? Why do we recommend them?
So the flu vaccine is challenging to manufacture because every year there are slight changes in the types of flu that are in circulation. So people who manufacture them have to keep that in mind and kind of predict every year which strains are going to be in circulation. So given the challenge involved there, people might say, well, some people got the flu shot and they still got the flu, so why should they? However, most of the research shows that if you do get the flu, even after the flu shot, it will typically be milder. Most of the cases of serious flu illnesses and even deaths tend to occur in people who have not had the flu shot. So it is the best protection out there, even if it's not 100%.
Yeah.
So we do recommend every year to get the flu shot, and especially for younger people, older people, and patients who have any kind of severe underlying illness, which may put them at high risk of severe disease.
Yeah. So just important for my patients and parents listening, flu vaccine is licensed for children over 6 months. So if your baby is over 6 months, you can start vaccinating. And it's usually recommended that the entire household be vaccinated, not just one or two people within it. And it's usually, just correct me if I'm wrong, it's usually the extreme ages, the very young, the very old, and those with chronic diseases who end up dying from complications of the flu.
Correct.
Okay. All right. Now I've had a few parents, this one parent ask, what are the clinical symptoms of pneumonia?
So I still remember when I was in medical school, what they taught us was that there were two signs that were the best in the WHO recommendations to diagnose pneumonia. And they looked at this across a broad spectrum of ways to check for pneumonia. And one of them was fever, and one of them was an increased respiratory rate. And especially in third world settings where you don't really have access to many other things like chest x-rays, that is the best way. So if the child is running a fever and you notice that they're breathing fast, then there's a very high likelihood that they will have a chest infection.
So it's just to reinforce from the parents, it's not the fever alone. It's if your child is having fever and they're breathing fast. Okay?
Absolutely.
That they have, because every child with a viral cough and cold will come down with some degree of temperature. And otherwise, I'm going to have every parent running to me to my clinic. My child has pneumonia. So it's a combination of pneumonia. And I teach you guys this when you guys come to my clinic. I explain to you the importance of understanding how your child breathes so you know when to react. Okay. I thought we will touch upon another topic, which is about brufen and paracetamol. What roles do brufen and paracetamol play in coughs and colds and these sort of upper respiratory viral illnesses?
They really don't have any role in these upper respiratory illnesses. If there is fever with the cough and cold and the fever is significant, then you may give some Tylenol or paracetamol or ibuprofen for the purpose of making the child more comfortable. But in the typical URI, cold and cough, there is no role for Tylenol or brufen.
And I usually, if you can also touch upon fever, because I usually I try to explain, again, over here in Karachi, and you grew up here.
Yes.
Over here, we're still living in that drama where if you see some of the, I saw this Turkish drama, this child is having fever, the fever's not coming down, everyone's concentrating on the fever. We no longer concentrate that much on the fever. Hana? It's like we note the child has fever, we note the degree of the fever, but the fever itself does no damage. I mean, do you agree with that?
Correct.
And you don't.
Yes, the fever itself is not harmful. It's just a sign that there's something going on in the body and the body is trying to fight it. If the child is very uncomfortable with the fever, certainly by all means you should give medication to control that. But the fever in and of itself is not the problem. It's just a signal.
Yeah. So that's why I keep telling people, as a fever is your friend, not your foe. It's your body fighting. And it's just really important. Yes, register your child has fever. Always measure it. Don't just give your Calpols and your Panadols and your Brufens without measuring. Strip the child naked and then see other symptoms. What is your child doing otherwise? Okay, that's really, really important with the fever. Okay.
And
and
the child's general appearance. That is what we always stress here. If a child is generally looking fine, smiling, active, and has a high fever, it's very unlikely there's something serious.
No, because a few months ago, the BBC did this one doctor from the UK did an article, Calpol, which is your paracetamol, or in the US, your acetaminophen, is the new heroin for children. Because it's like, it's not addictive, but it's sort of a to-go to most of the GPs. They'll just prescribe it to make the parents feel happy that they're giving something. So because we stopped giving cough syrups and everything else, they just tell them just have the Calpol, okay? And we were trying to work on it over there before I left the UK, and I'm trying to work it over here. I say Calpol is a good medication, but it's not going to do much more than help bring the fever down. But you need to strip your child naked. If your child is all bundled up, fever is not going to go anywhere. So somebody asked about fever medication, pain medication called $DS in Pakistan. It is mefenamic acid. Have you heard of it?
I have heard of mefenamic acid. It's not very commonly used in the US though. So I just remember from medical college days.
So I did, I have been checking up on this because we no longer use it either in Europe or the US, because I even spoke to my sister about it and several of my colleagues. And it's not licensed for children under 14. In the US, it's not licensed for children under 14, and in the UK, not under 12, because the safety and efficacy has not been shown. So Aisha Raja Khan, I would not advise you to use the $DS. Okay, so we've touched upon quite a few topics, touched upon fever. Then gastroenteritis. We did discuss this last week with Dr. Amana also. I'm just hoping that, with the more experts I discuss it, the more people will understand what gastroenteritis is. So what is the most common cause of gastroenteritis?
The most common cause is viral.
Yeah. And sorry, it's like a pop quiz. So I usually say, your viral gastroenteritis, we usually say can go up to a week. So there's no issue with that. Can be very watery. You can have fever. You can have stomach aches. Can you just highlight the important red flags of gastroenteritis in the stool? What do you see in the stool where it has you concerned?
Well, what I usually ask my parents is, have you seen any blood in the stool? And have you seen any mucus in the stool? Mucus doesn't concern me as much, because occasionally, even with viral gastroenteritis, you may have a small amount of mucus. That may not be an issue. But if you have mucus and blood, then I'm more concerned that there could be a bacterial process going on in this setting. And of course, in third world developing country settings, you have to consider the parasites. Now, over here, rotavirus used to be the most common viral gastroenteritis, and I do believe rotavirus vaccine is now available in Pakistan, but I'm not sure how commonly it's given.
So it is. So in the areas where we live, so Pakistan is a dichotomous society, unfortunately. So you have your well-off areas where you have your water and sewage and everything which is dealt with. So we don't tend to see so much of the bacterial gastroenteritis. I have, since I've come back, we've been treating them all as viral. They've been literally, in the past 2 years, they've been literally only 4 or 5 who have, when they had a bit of spots of blood, or mucus in the stool, we did send off a sample then. Even then, we didn't treat. We sent off a sample, and they came back as positive. For one was Salmonella, Shigella, and but the child was doing much better, so we didn't treat, and the parents were happy not to treat.
Yes.
So that's
Yes.
another important thing to say. If your child is improving, even if they test positive, they're quite well at recovering even from certain mild bacterial gastroenteritis.
Correct. Even in the US, we rarely treat bacteria. Even bacterial gastroenteritis is rarely treated.
Yeah. And just to highlight, the single most important thing in gastroenteritis, parents, is hydration. Hydration, 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 hydration. ORS is your best friend in gastroenteritis.
Absolutely.
And
ORS or light if that's available there.
Yeah, yeah. And you want to wait 2 days. No, not wait, but I'm saying you can have vomiting with gastroenteritis, but after 2 days of vomiting, you really must come and see the doctor.
Absolutely.
Yeah.
Yes.
Okay.
And definitely if there's anything green in the vomit, if there's any blood in the vomit, then don't wait.
Yes, absolutely, absolutely. Okay, now we're going to touch a little bit on typhoid. So we're having, unfortunately, due to the massive use of antibiotics, you have parents, not just parents, I have friends who go and say, I'm feeling really sick. Well, they know now never to tell me that, because they really give them, I'm known as lecture Anokhi. They know me no longer. They're like, you're always prepared with a lecture. They're like, I'm feeling really, really, really sick. I'm too sick to go see the doctor. I can't be bothered. I'm just going to start some antibiotics. So, yes. So because of that, and it's not just that, it's antibiotics are so easy to access. You go to the pharmacy, you don't necessarily, they'll give it to you without even a prescription. It's practiced a lot. Your parents think, and patients, not just parents, adults, everyone thinks if I get a shot of antibiotics, it will prevent me from getting sick.
Yes.
I have friends who call me from their select has one friend calling me from London. He was like, I got a really terrible cold, but I have to go to office and to work. I'm visiting London. Can you just, message me over a prescription? I was like, well, first of all, I'm a pediatrician, so I'm not allowed to message you over a prescription. And I was like, second of all, it's a virus. You don't need antibiotics. And I was like, go see the GP there. You go see the GP, and the GP says the exact same thing as I did. Okay. So we have, my little rant here was just to highlight, okay, we do have increasing number, it's very scary, increasing number of drug-resistant typhoid in Pakistan.
Yeah.
Okay. But because it's one of the scary things that comes out there, I was wondering if you could just highlight a little bit about what typhoid is and what are the diagnostic tools.
So typhoid is a serious illness that's caused by a bacteria called Salmonella. Just to make it clear, there are different types of Salmonella, and most of them are not as serious as typhoid. But typhoid is caused by a particular strain of Salmonella that can have very serious consequences. It can lead to problems in the liver, in the spleen, in the bone marrow. But typically, it presents with very high fever, and children can end up, and even adults, this illness being very sick. So the important thing to note in typhoid is if it's treated, diagnosed correctly and treated on time, it's very treatable. But a lot of times there are delays in diagnosis, partly because patients develop fever, they go to a physician who then starts them on antibiotics without really coming to an accurate diagnosis necessarily. And then when an attempt is made later to make the diagnosis, it's too difficult to make that diagnosis because now they've been partially treated.
Yeah. So, I mean, I usually, so what I have read and understood about typhoid and what we've been taught is it's a very mischievous illness because it doesn't always present the way you would expect it to present in textbooks. So that's why it's something and I try to explain this to parents, and I was like, something that you always think of if your child is having, in Pakistan particularly, if your child is having prolonged high fever. I mean, I think that is the baseline one for typhoid over here. Otherwise, it can present in all shapes and sizes. Blood tests for typhoid.
Blood tests for typhoid can be tricky. Usually you can do serologies, which will show you if there's a sudden rise in the serologies that can tell you that there is a recent typhoid infection. But a lot of times you may not be able to necessarily get the result that you're looking for with typhoid, especially in complicated cases or if they've been treated and things like that.
Yeah.
So I don't know if you necessarily have a very good response from the blood test these days.
No, unfortunately, and I've had some cases who were admitted in hospital, but again, so serology is your when you're looking at particles, see if you have reactive particles to the typhoid. The blood cells are reacting to the typhoid. That's what your serology is. But yes, it is very, very difficult still. The blood cultures, everywhere it's written gold standard blood cultures, gold standard blood cultures. But then when you read, for an adult, it says you need at least 220 ml, like big blood culture samples, and you need to get it done twice. So in kids, where, as far as I understand, because of the small sample that we end up taking from them, most of the cultures do come out negative, but that doesn't necessarily, I mean, do you agree? That doesn't necessarily mean that your child doesn't have typhoid. It helps you confirm.
No, the blood cultures are not very reliable.
Yeah.
They typically, for most bacterial illnesses, you have a relatively low yield for blood cultures.
Yeah, especially in kids. So it's and in an endemic region like Pakistan, you have that, what was it called? The Wendel's typhoid test.
The Vidal test.
Vidal test, sorry. The Vidal test is no longer recommended because it'll come out positive because it's endemic here. So you don't necessarily have to have typhoid and it will still come out positive. So it's very, very tricky. It's based on, when parents ask me, how do you know? I think it's based on a combination of what your blood looks like and how your child is doing. So there's no button to press to say typhoid yes, typhoid no, unless obviously the cultures come out positive, then it's like very obvious.
It tends to be more of a clinical diagnosis and ruling out other causes.
Yeah, exactly. So one of the parents asked, is typhoid contagious? How does typhoid spread?
So typically in areas where you have poor sanitation, you'll find those areas tend to be higher prevalence rates of typhoid. So you can have cross-contamination with the sewage and the water, and this is one of the leading causes of spread. But it has to be, that strain has to be present in that environment.
Yeah. So it's the oral fecal route in our area where we are. Yes, please boil your water. Do not drink your water. Make sure the tap water. Make sure your child is brushing their teeth with bottled water. It's really sad.
Or boiled water.
Over here it's over here. As I don't even bother boiling the water. It's just bottled water.
Wow.
Even in the slums, they don't take the water there. They have bottled water.
Wow.
Yeah, it's like, and I think it's absolutely horrendous. I mean, it's a basic human right to have drinkable water. But because we've got so many funky stuff in our water supply that even for cooking, we have a separate filtered water that we get and bring in. And yes, definitely brushing your child's teeth has to be, use a bottled water, or if it's got an ultrafiltration, if you've treated your water that's coming into your tank and then boil it, then that's fine. But otherwise, just taking the water from there and just boiling it is not good enough, in my opinion.
So pre-treated and then boiled is okay.
Yeah. Sorry, some of my naughty friends, they know I'm online and they've forgotten and they're calling me. Okay. So let's go through the questions, see if anyone's... How to build the immunity of my child in the winter months? You want to highlight that? It's a common question I keep getting. How do I build my immune system? How do I build my child's immune system? And just remember, these are kids who have no routine, going to sleep at midnight, no balanced diet. And then the parents come to you and say constantly, the child's constantly sick.
The one thing you can actively do to build the immunity is vaccinations. And you should make sure you get all the recommended vaccinations on time. The other thing you can do in the house is just focus on a healthy lifestyle, regular sleeping habits, good diet, lots of fruits and fresh fruits and vegetables, lot of protein, good nutrition, and exercise. Those are the things you can really do actively. Other than that, good hand washing, good hygiene, these will all factor in. But other than that, your child's immunity should develop naturally with age. By the time children reach about 5 years of age, they should not be getting very frequent infections anymore, and their immune system becomes more similar to an adult.
Yeah. So normally, the way I try to describe it to my parents when they come in and they're like, under fives, they're constantly sick. I used to say, is just imagine your immune system has filing cabinets. Us as adults, the filing cabinets are like they're bursting with information of all the things we've been exposed to over our lifetime. So our body knows, oh, this bug's coming. We have a record, pull it out. We know what to do. This is the recipe to destroy this bug. But the kids do not have that. They're building it up. So their filing
Correct.
cabinets are still relatively empty. So every day, every minute, every second of the day that your child is being, and yourself, every human being is being bombarded with bacteria and viruses. And basically your body is fighting non-stop. And through that fighting non-stop, it's building up its defense mechanism and its memory about all these bugs. And then of course, unfortunately, because they don't have previous memories, sometimes certain illnesses actually do present as certain bugs do invade the system, and your child actually presents with illness. It's really important to remember that these are symptoms, because a lot of parents will be like mucus, cough, all this stuff. Is this the disease? I'm like, no, it's a symptom of the disease, and it's your body fighting.
Yeah.
So why don't you highlight what happens in a child with asthma or a wheeze who has a cough, and you give them a cough suppressant?
Well, we actually discourage strongly the use of cough suppressants in children because cough, for the most part, is a protective mechanism. So if the airways are irritated due to an infection, there's a lot of mucus production, and that mucus needs to come out and be expelled by the child. If you give a cough suppressant, that mucus can no longer be expelled as effectively, and then it can lead to some level of obstruction in the airways, and then even in some extreme cases, a little bit of collapse of the lower levels of the lungs. So you may actually do more harm by giving a cough suppressant in such situations than good.
Okay. Coming back to the upper airways, tonsillitis. Would you be happy to just tell me a little bit more about tonsillitis for our parents?
Sure. So tonsillitis, the tonsils, first it's important to understand what are the tonsils. And the tonsils are basically a collection of lymphoid tissue at the back of the throat. And they serve as sort of a first line of defense. When bacteria and viruses try to enter the body through the mouth, then the tonsils can catch those bacteria and viruses, so to speak, and try to prevent them from getting any further. So tonsillitis is basically inflammation or a response to an infection of these tonsils, and it's a protective mechanism for the body that now this infection has come, we need to stop it at the gates to the body, so to speak, and help control it. And it may be viral, it may be caused by a virus, and there are also certain bacteria that can cause tonsillitis. So depending on the etiology, the treatment of tonsillitis is based on what is causing it.
Yeah. So how do you differentiate between a viral and bacterial tonsillitis?
Well, with a bacterial tonsillitis, typically you will see that the tonsils will be very large, red, inflamed, and you may also see some mucus production and some pus on the tonsils. And whenever you see pus, that's usually a sign that you do have a bacterial tonsil going on. Over here, typically we do throat swabs as well. I'm not sure how useful they are or how much they are there.
No, so I have the strep test, the rapid strep test. My sister brings them in, so we do the rapid strep test.
Okay.
And
then throat cultures, do you do those as backup or?
Yes. Okay. So if they come out negative, we send a second sample to the lab, And pretty much they say the same thing as the rapid strep test, that it's negative so far. And in majority of the cases, again, it's important to highlight to parents that the majority of the cases of my patients who come with tonsillitis have all been viral. The strep tests have been negative.
Yeah.
And the child can have high fever, can be miserable, sore throat. The severity of like how bad the throat is hurting doesn't often help to differentiate between viral and bacterial. No, because I'll have parents saying that it's hurting a lot, And I'm like, we've done the strep test, we send them the throat culture, the cultures come negative. This is just a viral tonsillitis.
Yes.
So fever subsides, and then slowly the tonsils also recover. I mean, we've had cases of Epstein-Barr virus, mononucleosis tonsillitis, EBV, which when I was in Switzerland, we had one very severe case. She was a teenage girl, and she just literally could swallow nothing. We had to admit her just to hydrate her because it was so bad. And we didn't give her a drop of antibiotics, just painkillers and hydration, Can you highlight what happens if you give a child with mononucleosis Augmentin?
Yes, that's something that's seen pretty commonly. If you give Augmentin in a child thinking they have a bacterial pharyngitis or tonsillitis, you can end up with a pretty extensive rash as sort of an allergic reaction to the combination of Augmentin with the virus. So it's always recommended to avoid using antibiotics if there's a possibility of yes.
Okay. So just two more things that I just wanted to touch upon, if you still have time. One is, so we've already done the typhoid. The next is dengue. What can you tell us about dengue?
So dengue is another febrile illness that's usually spread by mosquitoes and is very common in certain parts of the world, amongst which unfortunately Pakistan is one of them. Most of the time, dengue is what we consider fairly benign illness. It does not lead to very severe illness or death, but there are certain strains of dengue that can be more severe. Usually dengue self-resolves. It usually comes with fever, joint pains, sometimes a rash, and you may have certain changes in the blood cells, but typically they tend not to be very severe. And usually you just have to give supportive care for dengue, which is fluids, perhaps if you need it, the rest, Tylenol for fever. There's no role of antibiotics in dengue because it is a virus again, so it's not caused by a bacteria.
And we have a test for dengue, the dengue antigen test. So usually that's how we basically diagnose dengue. Then we have the next one is malaria. So surprisingly, I've not really seen much malaria coming back to Pakistan.
Yes.
Can you tell
malaria
me a little?
A more severe, also a severe illness caused by a parasite that invades the red blood cells, and it's one of the oldest killers in the world and still has a very high rate of complications. It's also spread by mosquitoes, and unlike dengue, you do need to treat malaria as soon as the diagnosis is made, or even before if you have a suspicion. And if it's diagnosed accurately and treated on time and the patients are watched carefully, then the outcome can be very good. But it can be a little tricky to diagnose at times because there can be other diseases that mimic the symptoms of malaria, and there can also be different types of malaria and can present in slightly different ways.
Yes, yeah. So what is your opinion on the antigen test for malaria?
Antigen tests are usually helpful in that they come back quickly, but they're not always very sensitive. So you may get a false negative result quite often, and you should not let that mislead you, because if the clinical picture looks like malaria, then you should treat.
Yeah. So normally we always used to, and we still recommend, you need to do a serial blood test, thick and thin film, and usually prefer you want to do it when the child has fever. So we used to do at least 2 days, 24 hours apart. We used to bring the kids in to do a thick and thin film. So it's just important to highlight to parents it's not medicine in pediatrics and even in adult medicine. It's not always a straight answer, yes or no. As you've noticed through our discussion, we have a lot of symptoms of different illnesses overlap. So even though we're assuming it's one, it may be another. So it's always important to keep that in your differential diagnosis. So when we as physicians are thinking, we're always thinking, you know, is it this or is it something else? Sometimes parents get horrified when I say you need to do another blood test, another serial blood test, you know, because things are not resolving. So the initial diagnosis, you know, we need to check and, you know, expand, okay, you know, is there anything else we're missing? Because which is completely understandable, is you don't want to unnecessarily poke this child and they just want an answer then and there. And the modern medicine in the current field of pediatrics, so I'm a pediatrician, so I'm going to talk about pediatrics, is we want to, and I still try to do it as much as possible over here, but due to diagnostic restrictions, not always possible, is that you want to identify a cause of the illness. You want to try as much as possible, name the disease. And
For sure.
always try to keep it at the back of our mind. Okay, we may be wrong and this may be disguised another, you know, disguised as another. Okay,
Yes.
so medicine is not straightforward. I keep having parents asking, oh, it's a good question for you. So how do you differentiate between a bacterial and a viral infection?
It's tricky. Usually with most viral infections, the child's general appearance is the most reliable clue. With viruses, you can have extremely high fevers. With bacterial infections, again, you can have extremely high fevers. But usually the child that you'll see who has a viral infection will improve in appearance when the fever goes down. And even when the fever is high, may not really look all that bad. They may still be active, playing, doing whatever they need to do. Whereas with bacterial infections, they do tend to look more sick. They may not improve as much even when the fever goes down. They would probably be more lethargic, not eating as much, just lying there. Those to me are the most reliable indicators of
yeah. And this is what we always, I stress in my clinic. Okay, it's really important. I mean, this is where we're coming back again to fever. Okay, it's not the fever itself, it's what the child's doing with the fever. And I stress over and over again. I was like, if your child is really unwell with the fever, you bring the fever down and see how the child does. If your child does not pick up, that is a red flag.
Yes.
Okay. All right.
And one other thing we also look for is if the fever does not go down with the antipyretics, that also is a red flag too. It should be coming down.
Yeah. Now the issue here in Pakistan is you'll have parents giving one form of Calpol and it doesn't work, and yet with the next dose, if they give Tylenol, it works miraculously. So we've got a lot of dilution of medication.
Yeah. That can be a problem.
It's So I don't know. It's anecdotal information, feedback I'm getting from parents who'll be like, we only use Tylenol because when we tried the Calpol, it doesn't work. But then other ones use Calpol and they have no issue with it. So it's really, really, really hard to tell. Okay. Right. So just to highlight what we've discussed is coughs and colds. Coughs, there are no cough syrups for kids. Not recommended. Okay, especially not under 6. No medications. I keep having parents messaging in, calling, asking, do I have any cough syrups? Can I give any cough syrup? Make no difference. Saline nebulization is a placebo. It's really not going to do much of a difference other than clean your child's nose. It's expensive, difficult to like carry around. And to be completely honest, Sabiha, we have a nebulizer for my mom. She's incredibly sick. And I realized we've been very naughty. We've not changed the mask as frequently as we should. So then that's also a source of infection and contamination, if you agree.
Yeah.
Yes. Nebulized medications in bronchiolitis, there's no proven place.
No.
Atom or ipratropium bromide, we're really not using it that much anymore. In the UK, we do use it a little bit in bronchiolitis. We give it a try. Doesn't work, we leave it. We're a little bit slow about moving away from old medications, some of us. Okay, I'm guilty of it. I think we're all guilty of it. Ventolin, Again, no place in bronchiolitis. Definitely no place for steroids in bronchiolitis. You got the brand names, you got your Euclenil and current composites here. Talking about medication, before I forget, I just wanted to highlight. So over here, it's one of the standard treatments that I see coming through my clinic, where parents just started themselves, is that if the child has a cough, they start a steroid nebulizer combined with albuterol, which comes under the name of Clenil composite. Or if the child is wheezing, they start that also. So in the UK, Ventolin is your first line of drug as an inhaler form in a wheeze. And it's only if you're having recurrent wheezing episodes where you're requiring a lot of Ventolin do we start thinking about inhaled steroids. What is your opinion of that?
We follow the same practice in the US. The standard of care is initial wheezing, albuterol or Ventolin. And if there are recurrent episodes and recurrent, that classifies them into persistent asthma, then there is a role for inhaled steroids. Certainly just for a cough, it's not recommended to start using steroids, inhaled steroids. Although they are relatively safe, they are not 100% safe. We use them on a risk versus benefit ratio, and there's more benefit to a persistent asthmatic from using inhaled steroids than risk. However, in a regular child who's just coughing, there would be no benefit from the steroid, and there certainly may be some risk.
Yeah. Okay. And so basically with a cough, I usually tell parents it can go up to 2 to 4 weeks. You see the pattern, you see the child improving, the cough settling. I mean, I have a cough myself right now. It's been 2 weeks and it's like, I'm just doing the occasional, okay. But I know it's going to take time and I need to be careful because if I go into clinic and some child's going to cough in my face, I can catch another one.
Of course, yeah.
So a lot of parents get very frustrated. My child's coughing 2 days now, it's not resolving.
2 days is really not a significant number of days for a parent to start getting worried about. We generally reassure parents here 2 to 3 weeks of cough with an upper respiratory infection is perfectly normal, and sometimes it can go up till 4 weeks. If it starts to go beyond 4 weeks, then I would be more concerned, and I would certainly look into it. And there are a number of ways I'd look into it. But up till about 4 weeks, it's reasonable to use a watchful waiting approach.
Yeah. So that's another thing we need to highlight, that it's okay to wait and watch. You need to make sure your child is resting well, going to bed on time. 7:38 is usually your bedtime. You shouldn't be dragging your children out of bed in the morning. I usually tell my parents, okay, you're doing something wrong if you're having to drag your child out of bed. Your child should be waking you up. They should be your alarm clock. So
that's true.
Yeah, because over here you'll have kids, they're like, my child's a baby, so it's okay if they go to sleep at midnight. I was like, no, your child goes to the bedroom in bed at 7:30 and stays there till 7:30 in the morning, or when they wake up, to set a routine, to set their circadian rhythm, to ensure, a proper boosted immune system through proper sleep, balanced diet, really, really, really important. I know in the US, you do not recommend what you call multivitamins for children unless you think that they're not eating properly. In the UK, they've changed that guideline. They're now telling us to give everyone under 6 multivitamins. Yeah, well, basically they're seeing too many. There's still a small amount, but there's still a significant amount of rickets. So yeah. Wow. So it's like, I mean, I tend to leave it. If I think the child is eating well, I'm like, that's okay. You don't need multivitamins. But if the parents are really struggling with the food, I usually put them on a multivitamin. But it's a disputed thing because we don't know what it's really, whether it's True. Helping or not.
Yes.
So that's still. Okay, so I have. All right, Samin has written something, except I can't read it.
I read something, coughs tend to take some time to resolve. If your child is fever-free and just has a cough, when is...
Yeah, I know. It won't let me see the rest of it. Okay.
I guess what she's probably saying, when is the time to get worried about the cough, I would imagine, right? When
Yeah.
maybe exactly the time frame we gave.
So it's
So
about
I would say 4 weeks. If the cough has not resolved, that would be the time to remind your doctor that it's been 4 weeks now. Should we look into it further or try something else?
And it's just remember also, as we mentioned at the beginning of the talk, is that especially when your child is in a play group or going to school, they're constantly being exposed to coughs, other
Correct.
kids with viruses. And I usually say you see a pattern of a wave. Sort of like the child is getting better, is nearly better, and then suddenly, boom, another cough has come, cough and cold. And that usually is a new infection. And you
Yes.
usually see it very clearly. The child is almost recovered, and then suddenly, so it's not a relapse. I usually say it's not a relapse, in my opinion. It's just a new infection. And then it's usually typically when you ask them, yes, it's going around school. There's another viral illness going around school. Okay. Does anyone else have any more questions? Because I think we've touched upon pretty much everything. I know a lot of you were talking about, so let me just check here. Sorry. So again, it's very simple. It's very basic, parents. Okay, there are no more questions there. It's about a balanced diet. It's about proper sleep. It's about hand washing. It's about not. Oh, okay, yeah. Samin's question has come through. When is it safe to send her to school when the child is having a cough?
Usually we don't hold back from going to school under typical circumstances. If there is a viral infection, it's most likely to be contagious during the first few days before she starts and then the first few days after she started. So definitely within about a week, they should be good to go back.
Yeah. No, because it's going to be, and that's what I usually tell them. I was like, when the child is beginning to improve, you just keep them home for 2-3 days, see that they've rested, they have fluids, they're getting better, then you just send them back in. But not all parents do that. They're like, my child is like, nose is running, they're coughing, hacking all over the place, and they send them in. And just remember, parents, if you're going to send your sick child in without giving them a day or two of rest when they've just come down with something, it's going to be difficult for the child to get better.
That's
because
true.
your immune system is being compromised, because your energy is being diverted to your child playing around and being exposed to other kids and all the excitement that comes with school. Okay. So I have a parent who says, my son got blood infections, got rocephin, which is ceftriaxone, for 2 to 3 days. What is the question, Bilal Mohal? So I think he's basically talking about sepsis.
It sounds like,
yeah. So just if you can just we're nearly done. Just 2 minutes, just explain a bit about sepsis and what we do with it and how important
Sure.
it is to treat it.
Well, typically what used to happen in the days before we had the pneumococcal strep pneumoprevnar vaccine, a lot of children who develop fevers in the age group between newborns 3 months to 36 months of age would end up with fevers, and then at that time it was not clear whether this is a viral infection causing the fever or is it a bacteremia that leads to sepsis. So the standard of care used to be to draw blood culture and then give the child a few shots of rocephin in case there was a bacterial infection, to cover that child until you get those results back and you know for sure. However, now, because we do have almost universal immunization of children with the Prevnar vaccine, the standard of care has changed a little bit, because most of the causes of fever in this age group tend to be from other causes like viral or urinary tract infections. So this role of managing with a few doses of rocephin has relatively become obsolete in the US.
Yeah.
Now in Pakistan, where the setup is a bit different, you may not have fully immunized children, there may still be some role for this practice.
Which age group did you say? I'm sorry, I missed the big.
Typically, it's done in like the children who are older than 3 months, so out of the neonatal period.
Yeah.
And
No, so we don't. It's because the kids here in Karachi, particularly, you have to remember, most of the kids, the EPI program is very good, and a large proportion of our kids, especially those who are in the areas where we practice, they're all fully immunized. So we don't, well, you don't see that much as you would before, but yes, in the rural areas, in the poorer areas, it's still practiced that way. I go to a charity clinic, and over there I see a lot of kids coming in who have clearly viral illnesses and they are being immunized, but because they had fever, they've received a shot of Rosefin with ceftriaxone. And just to answer your question, Bilal, a child who does have a proven, so a raised CRP is not a proven sepsis. It's when you have, it depends, you put symptoms together, it depends on your blood cultures also. But if your child has a proven sepsis where the blood cultures are positive, not just the CRP, so your child was started on IV medication because obviously there must have been symptoms that had the physician concerned. With a raised CRP, he said the CRP was 33. Obviously, I don't know what measurement we're using, what unit. So with the raised CRP, that's most probably why they started the ceftriaxone. And when they saw that the blood cultures were negative, they would have stopped it. We do that with kids also when they're very, very sick, and we've explored A to Z and couldn't find anything. And children under 3 months. Children under 3 months, we just treat them straight away. If they come in with fever, they get a full septic screen, which includes, and they should be getting full septic screen, which is your bloods, your LP, which is you take fluid from the spine, you get your urine cultures, and then you start the baby. If the baby has fever, you start them immediately on IV antibiotics, and then you discontinue them once you have all the cultures back and everything is negative and your child is okay. But with older kids, we don't do that. But if you do have a proven sepsis with a proven culture, what is, I mean, it's usually 14 days of IV antibiotics, isn't it? 7 to 14 days, depending.
Yes, and depending on the and the cause, and that's if you've ruled out meningitis for sure.
Yeah, yeah. And if you have a proven meningitis, and I said proven, I've discussed cases like this with you before, if you remember, 2 years ago.
Striking some. Yeah.
Yes, which is very, very concerning. So a proven meningitis, or if you have bacteria in your joints, though we had a case of a bacteria that not only was it a proven sepsis, but also went into the joint. Those need at least 21 days of IV antibiotics. Am I correct in saying that? So
absolutely.
Yeah.
Yes.
So
and even longer.
Yeah, and then you obviously you see how the child's doing, and you do. That's where CRP is helpful. When you see the CRP coming down, when you're treating the child, I mean, correct me if I'm wrong. I've not been in a hospital for 2 years, but usually we've always used the CRP to see, is this antibiotic working? Because then you see, because CRP, the half-life, it sort of spins over within 24 hours, 12, 24 hours. So then you can see it sort of dropping, which basically means the inflammation is going down, which basically means whatever you're doing is working. And when the CRP is completely normalized in a proven sepsis, that's when we stop. So like he was only given 3 days. Yes, Bilal, but the CRP is, as I said, the CRP alone is not an indication of sepsis. You can have viral illnesses also that can have raised CRP. You have to take the whole picture together. So they must have been concerned. Your child must have been sick. They must have been concerned, and that's why they started. We do sometimes in children who are looking well. So if a child has fever and a non-blanching rash, we've always treated it as sepsis. The child is doing really, really well. So in those cases, in very exceptional cases, we've given them the ceftriaxone IM, intramuscular, and sent them home and brought them back every day. So keep safe from viruses. It's just about proper sleep timings, proper balanced diet, vaccination, and hand washing. It's all about hygiene. Anyway, Dr. Sabiha, it was really, really nice of you to come on.
Thank you so much.
Talk to us. Thank you for giving us your Saturday evening. So everyone, it's actually Saturday out there. So Dr. Sabiha has given us an hour of time on a Saturday evening when she should be resting, recovering from hard work week work. Okay.
It
All
was
right.
my pleasure, Dr. Anokhi. Anytime you have any questions, feel free to shoot me a line. And if you want to do
I
another
always
talk,
do.
I would be happy to.
Yes, absolutely. We'll do another talk again sometimes. And yeah, and thank you always. Whenever I'm stuck with infectious disease questions, I always shoot you a line, and you've always been extremely helpful. Thank you so much. All right.
To oblige, and keep up the good work.
Thank you. All right. Bye, Dr. Sivia.
Bye.
All right. Thank
Bye-bye.
you, everyone. I'll let you know when I do my next chat. Okay. So keep an eye on our space. Okay. Bye.
Bye.